You are watching video 5.1 on QRS interval. The QRS interval represents conduction through the ventricles through the His-Purkinje system. The normal QRS complex is going to be something like 0.06 to 0.10 seconds. That's going to be 1.5 to 2.5 smalls. We will not regard it as completely prolonged until it gets greater than 3 small boxes or 0.12 seconds. As an electrical impulse, imagine that you're driving in a vehicle and you're in a hurry to get somewhere that you need to go. You're taking your normal efficient pathway to wherever it is that you're going. You come upon a closed road. Now you're going to have to take a detour, and as you take a detour, that is increased time in the vehicle and increased distance. Now if you think that you're an electrical impulse instead, if we were to take time and distance and convert those into time and voltage, then the normal pathway that you normally take would look something like this in terms of a QRS complex. In the case of your detour, if that time and voltage were represented in the QRS complex, it's going to look something like this, wide and with unique characteristics. So now we're going to turn our attention how delays in conduction can produce abnormalities in the QRS complex. In the case of a right bundle branch block, we're going to see that some kind of disease process, or perhaps no disease that we can identify, is going to inhibit conduction through the right bundle. As a result of that, we're going to see unique EKG characteristics. Starting with panel A, we can see in V1, because the left side of the interventricular septum is still viable, we are going to see business as usual in terms of the manifestation of a septal R wave in V1. Up in V6, we're still going to be able to see a septal Q wave because, again, the left portion of the ventricular septum is intact, and that's part of a left bundle function. Now, usually we would see the combined right ventricular and left ventricular depolarization going on to produce a much larger S wave in V1 and then a much larger R wave in V2. However, because there is a right bundle branch block, we're not being able to see that complete summation of the entire right and left, so we are seeing a much more subdued middle wave in the QRS complex. Finally, the impulse does make its way around the detour, and so we do see the completion of the right ventricular depolarization, and here in V1 we can see that it is published as a second R wave or a prime R wave, and then over here we can see that it is a second R wave. Consequently, right bundle branch blocks are going to look something like this. We're going to have a QRS complex that's greater than 0.12 seconds, and then when we look at V1, we're going to see an RSR prime. This one's pretty robust here. An RSR prime is also possible in V2, and then sometimes we'll also see what we call this broad S wave in lead 2 and then over here in V6, and that again here in AVF is simply representing the delayed depolarization of the right ventricle. Here we can see the broad S wave is more prominent in lead 1, in AVL, and then in V6, and then again we do have our RSR prime in V1 and V2. So for a right bundle branch block, we need a QRS complex that is greater than 3 small boxes. Then we should see an RSR prime in V1 or V2. Some authorities require a broad S wave in lead 1, AVL, and V6, which you can frequently see. Now, a right bundle branch block may not be associated with any specific disease and may be an isolated finding, but it can be seen chronically in the case of pulmonary hypertension and stenosis, or acutely in the case of a pulmonary embolism. Also, we can see a right bundle branch block in congenital heart disease like an atrial septal defect, and then it can be associated with a myocardial infarction. If you do have a right bundle branch block in association with a fascicular block, then that's going to be worrisome for subsequent third-degree heart block. More on that later. Brugada syndrome is not a right bundle branch block, but it is a conduction abnormality that can be proarrhythmic, and I put that on the list because sometimes you can confuse Brugada syndrome with a right bundle branch block, and so we'll talk more about that later, but it's important to know about that as a condition. Let's take a look at this 12-lead EKG. Here we can see that the rate is 300, 150, 175, so I'm going to estimate the rate to be somewhere around 85, and then we're going to look for rhythm. I can see P waves here that are upright and essentially normal in appearance and 1p per QRS. I am looking for inverted P waves in AVR. I have found them, so we have sinus rhythm with a rate of 85. Next up is going to be axis. I can see that lead 1 is overall net positive. The voltage is significantly skewed in AVF, so I can look for confirmation here. And because the lead 2 is overall net positive, I'm going to say that this is a normal leftward axis. Now we're going to move on to PR intervals, and I can see here that the P wave, the PR segment, and the initiation of the QRS complex are all well within one of these intermediate boxes. The PR interval is normal. Now I'm going to move on to the QRS complex. Now I can see that the QRS complex adds up to be about 4 small boxes or 0.16, and so we do have a prolonged QRS complex. Now I shall turn my attention to V1 to assess for an RSR pattern, which clearly we can see with an R, S, and an R prime. So we do have diagnosis of right bundle branch block, which is also confirmed by the broad S wave and AVL and V6. In the case of a left bundle branch block, you can see that there is going to be a block in the left side of the intraventricular septum because of the location of the left bundle. Consequently, we are not going to see the left side of the septal participating in manifesting conduction in the form of the septal R wave or septal Q wave. Quite simply, the right ventricle and the left ventricle are going to combine and demonstrate their depolarization without that initial septal mark, without that initial septal depolarization. And the result is going to be something like here in V1, a kind of QS type of complex, and then an RS complex, or simply an R wave in V6. Consequently, we can say that anytime that there is damage to the left bundle, we're going to see this type of pattern in a bundle branch block. Specifically, we should see a QRS duration that is greater than 3 small boxes or 0.12 seconds. A broad or notched R wave in V5 or V6 like you can see here. Now sometimes it's not notched so much as it's just rounded, and that will count as being broad. Now anytime you have chest pain and a new left bundle branch block, that is considered a STEMI or a bad MI until proven otherwise. Old left bundle branch block with chest pain makes it difficult to assess for ischemic changes because of things like these inverted T waves here and here. That'll make more sense later on. Left bundle branch block can be associated with underlying cardiovascular disease, whether it's coronary disease, cardiomyopathy, or wear and tear from valve disease or high blood pressure. If a patient has underlying coronary disease or cardiomyopathy and a left bundle branch block, then that does increase mortality when it is in association with disease. And occasionally you can find left bundle in somebody without significant underlying disease. Let's have a look at this 12-lead EKG. Here we've got a rate of 300, 150, 175, one small box greater. I'm going to say a rate of, say, 80. I'm going to look for P waves to establish sinus rhythm. I look at lead 2 and I see a P wave here, and then I look up here and I see inverted P waves. We have sinus rhythm with a rate of 80. Now we will move on to axis. Here I have lead 1 is completely upward, lead AVF is completely upward. I have a normal leftward axis. Now I'm moving on to intervals. I can see that the P wave, the QRS complex initiation, and PR segment are all found within one intermediate box. My PR interval is normal in that it is less than 0.20 seconds or 5 small boxes. Now I move on to the QRS interval or duration, and I can see here that there is at least 4 small boxes that comprise the width of the QRS complex. And so now I'm going to look for indicators of bundle branch block. I'm looking for an RSR prime in V1 and I do not see one. Instead, I see something that looks like a kind of a big QS complex. I then look to the lateral leads, and clearly in V5 and V6, I see that prolonged notched R wave, and then I can see the same thing in V1, and then a dead ringer for a notched R wave in AVL. This, of course, is a left bundle branch block. Now, it is possible to have an incomplete bundle branch block, and so this is going to be the case anytime you see an RSR in V1 or a notched R wave in V6, and so they are suggesting a pattern of an underlying bundle branch block, but there is not sufficient delay through the QRS complex in the form of greater than 0.12 seconds. In those cases that we have a pattern that is present, but we do not have enough delay, we will simply refer to those as an incomplete right or left bundle branch block, depending on which pattern is present. We will now turn our attention to fascicle blocks, or previously referred to as hemiblocks. We know that the left bundle, because the left ventricle is larger, has to branch off and provide two subdivisions, the anterior superior fascicle and the posterior superior fascicle. Now, these fascicles themselves can be blocked because they are downstream from the left bundle and can experience disease processes themselves independent of the more proximal left bundle. Left anterior fascicular block. To diagnose this, first you need a left axis deviation that is more negative than negative 30 degrees. So lead 1 is going to be upright in its QRS deflection. Lead AVF is going to have downward deflection, and then when we look at lead 2, it is going to show overall net negative deflection, a true left axis deviation. Subsequently, we need to have a QRS complex that is less than 0.12 seconds to diagnose a left anterior fascicular block in isolation from a right bundle. More on that later. The subsequent characteristics are going to be something like this. In the lateral leads 1 and AVL, we are going to see a small Q and then a larger R here and here. And then in the inferior leads in 2, 3, and AVF, we can see a small R and then a large S wave. These will be suggestive of a left anterior fascicular block. A left anterior fascicular block is a fairly common and nonspecific pattern, although it can be found in association with underlying disease. Frequently, it can be associated with age-related degenerative disease. However, frequently it is the case that there is no identifiable cause. In the same way that you can have a left anterior fascicular block, you can have a left posterior fascicular block. In this case, we will begin by observing a right axis deviation. We can look down here at lead AVF and see that it is completely positively deflected, and then we can see that the overall net deflection in lead 1 is clearly negative. We do have a right axis deviation. We should also have a QRS complex less than 3 smalls or 0.12 seconds. Except in the case of a concomitant right bundle branch block. Now, the more specific features are going to be these. The more specific features for the left posterior fascicular block are going to be seen here. Starting in the high lateral leads, we can see that in lead 1 and in lead AVL, we have a small R wave, that's that first small movement up away from the baseline, and then a slightly larger, more prominent downward stroke from the baseline that represents an S wave. That is an RS in leads 1 and AVL. Moving on to the inferior leads, we can see that here in 2, 3, and AVF, moving on to the inferior leads in a posterior fascicular block, we can see that in these leads we will observe a very slight downstroke from the QRS complex, which represents a small Q wave, and then a larger, more prominent upstroke away from the QRS complex, which represents an R wave. That is a QR in leads 2, 3, and AVF. In addition to these features, we need to make sure that there is no other explanation for the right axis deviation. We should not see right ventricular hypertrophy, or if your patient has underlying heart In addition to these characteristics, we should see no other explanation for right axis deviation. That is to say, no right ventricular hypertrophy, lung disease, lateral wall infarction, or a pulmonary embolism. If we see right axis deviation, we want to sniff out those potential causes. And then if we have right axis deviation and these characteristics, we can identify a left posterior fascicular block. Now, a standalone isolated left posterior fascicular block is not that common. Usually posterior fascicles are Now, a standalone isolated left posterior fascicular block is not that common. Usually these blocks are found in association with a right bundle branch block. This, of course, is interesting. If we have 3 fascicles and 2 out of the 3 fascicles have been blocked, that could set the stage for additional problems. Let's look at this 12-lead EKG. Here we have got a rate of 300, 150, 175, 60, 50, a rate of 56. Rhythm, we have P waves upright in lead 2, and upside down in AVR, we have sinus rhythm with sinus bradycardia. When we look for ACT, we can see that lead 1 is overall net negative, and then lead AVF is right side up, and so we have right axis deviation. We then move on to intervals. Here we can see a P wave and the QRS complex all fits within an intermediate box. It appears to be normal. When we move over here, we can see for QRS interval, it just measures out to be greater than 0.12 seconds. So we look for patterns of right and left bundle branch blocks. Beginning here, we can see an RSR and V2. This is suggestive of a right bundle branch block. Moreover, as we move over here to the lateral leads, we can see a small R and a more dominant S wave and 1 in AVL, and then we can see a small Q and a more dominant R wave in 2 AVF, and to a lesser extent in lead 2. And so this is going to be a right bundle branch block with a left posterior fascicular block. So the problem with bifascicular blocks is that they can lead to trifascicular blocks. That is to say, if you don't have a left bundle and you don't have a right bundle, you've run out of bundles. You do not have electronic communication of the upper heart with the lower heart, and there is no organized activity going to the ventricle. This, of course, is going to lead to third-degree heart block, and so individuals with bifascicular blocks, particularly in the setting of myocardial infarction, are going to need an urgent electrophysiology consultation for a pacemaker. Now, sometimes you're going to find a QRS complex that is wide in duration, that's greater than 0.12 or 3 smalls, and then you're not going to have a bundle branch block pattern to hang your hat on or some other fascicular block. You then need to develop a differential diagnosis for widened QRS complex. Wide V is one mnemonic to help think about the potential causes of a widened QRS complex. W stands for Wolff-Parkinson-White. And then we have the I is intraventricular conduction disturbance, whether that be a bundle branch block or some non-specific intraventricular conduction delay, which is sometimes used to refer when the QRS complex is moderately widened but there's no existing pattern. We should also consider, particularly if the patient's ill, tricyclic antidepressant overdoses or the toxic effects of antiarrhythmics. Hyperkalemia or electrolyte disturbances are definitely going to be on our differential, as will ventricular beats or ventricular hypertrophy. If you're looking at a wide, funky rhythm, you need to make sure that it's not a low-grade V-tach, an accelerated idioventricular rhythm, or a junctional escape rhythm. Certainly, pacemakers can produce wide QRS complexes, as can hypertrophy, which we'll learn about next. To summarize, intraventricular conduction problems, if we have a QRS complex greater than 3 smalls and then an RSR in V1 or V2, then that's going to be suggestive of a right bundle branch block. If we have a QRS complex that is greater than 3 small boxes, and then we have this broad or notched R wave in V5 or V6, that will be suggestive of a left bundle branch block. If we have a pattern for a bundle branch block, but the QRS is not sufficiently widened, then we can simply refer to that as an incomplete left or right bundle branch block. If, however, you have a QRS complex that is very wide, but there's no pattern for a bundle branch block, then you need to develop a differential diagnosis for a widened QRS complex, which can include some very problematic conditions like severe hyperkalemia. Downstream from the left bundle, you can have a left anterior fascicular block, which is diagnosed when you have a left axis deviation, a QRS less than 3 smalls, and then that QR in AVL, and then RS and 2-3 in AVF. Lastly, in the case of a left posterior fascicular block, we will first observe a right axis deviation. We should then also have a QRS complex that is less than 3 small boxes, unless of course there is a concomitant right bundle branch block. Then the characteristic features of the posterior fascicular block are going to be the small r, large S in 1 in AVL, and then the small q and large R in 2, 3 in AVF. Keeping in mind that if you do have a left posterior fascicular block in association with a right bundle, that would very likely warrant referral to an electrophysiologist. Next up is 5.2, the corrected QT interval.